Once again, I'd like to welcome you all to today's webinar by Tay Park on diabetes and your eyes. Tay Park is a clinical nurse consultant at the Sydney and Sydney Eye Hospital. He is committed to working with people with ophthalmic conditions for over 9 years. His experiences have spanned acute emergency care, eye outpatient care, and complex ophthalmic inpatient care. He is driven by a desire to educate and prevent eye disease in the community. He has received his undergraduate nursing degree at the University of Technology, Sydney, and has completed a Sydney Eye Hospital ophthalmology nursing course. Recently, he's completed a graduate certificate in clinical redesign through the Agency for Clinical Innovation and the University of Tasmania. Welcome, Tay. Hello.
Hello. Hi, everyone. Let me just try and go show my screen.
Perfect.
Perfect. Right. Hi, everyone. My name is Tay. Nice to meet you all. Are you guys all able to see my screen?
Looks good.
Great. Oh, so we'll start because I can't see what you are seeing. So today we talk about diabetes in your eyes. I'll appreciate if you can hold up your questions, and I'll try to do my best to answer all your questions at the end of the session today. So starting from what is diabetes mellitus? So we'll talk about a little bit of general terms of what diabetes mellitus is. The word mellitus in Latin means sweet, and you've probably all heard about sugar and diabetes, or sugar controls, blood test or finger prick test and things like that. It's actually quite simple, but it is very complex disease. Diabetes is a chronic health conditions where it affects how your body turns food into the energy. So things like your bread, your carrots, anything that you contain carbohydrates, it breaks it down into the form of sugar, known as glucose. And we're trying to utilize that glucose into energy. So your muscle, tissues, your brain, when you think something, it all requires a bit of energy, and we're getting it from the sugar that we've broken down from your food. And if you think about how does diabetes change your body, or what does diabetes lead to, it's usually chronic long-term process. And if you can think of it as diabetes impacting your blood vessel, that would be great. Usually your normal blood vessels have lots of hemoglobins, carries lots of nutritions, oxygens, fresh blood going through, providing the great nutrition to your organ, your brain, your body. Whenever you're walking or breathing, this is what's happening. But with times, if you have a diabetes, which means that you've got lots of sugar in your blood vessels, then your blood vessels do go through a change, and these changes are slow usually, and with time it gets worse. So because you can see on the bottom here where the blood flow becomes more slow, as you can see, the oxygen, the hemoglobins are very tired because of the cluster. You can sort of see in the bottom blood vessels where there's not regular, almost a tunnel is not straightforward anymore. That's because of all these like sugary drinks or high sugar content diets. And it leads to multiple different issues. Now, today we're going to focus on diabetic eye disease, but I do want to point out diabetes is a very complex disease where it does involve lots of different organs. As I've highlighted there, it can cause kidney damage, known as a diabetic nephropathy. It can cause diabetic foot or diabetic ulcers. It can cause several vascular disease, which means that it can have a high risk of stroke. It can also impact your heart. You can have a chronic artery disease or ischemic heart disease, which means that you're likely to have a heart attack or heart issues because of diabetes. You also have peripheral neuropathy as well. So people may complain of poor circulation on your fingertips and your toes. And for those unfortunate patients, you may hear someone got their toe amputated. So diabetes in the long term is a very scary disease, and it can impact your life in many different levels. And the idea is trying to prevent that happening. In worst case scenarios, we talk about how does your diabetes affect your eye? We talk about diabetic retinopathy. But having said that, it can accelerate the formation of your cataract, which is actually your lens inside your eye. So I've got a little diagram here. Sort of works like your old film camera or pinhole cameras. So you've got nice clear cornea, which is your window part of the eye. And then you have the natural lens sitting there. And you've got vitreous body, which is usually fills in this big cavity at the back of the eye. And there is a retina, which is your film part of the eye. And you can see there's a vessels that goes along and provide nutrition to your film part of the eye. Now, just be aware when you open up your eyes every day in the morning, looking at image, your eyes are working really hard. So that photosensory tissues in the retina, they're working very hard. And most of the visions are focused on your macula. Hence, the macula is very important because it does provide you vivid, high definition image to you. All this sharpness, vivid colors that you can appreciate with good visions, they are derived by a small area called macula. So if you look at my slide here, next to the light bulb inside the eye, that little round sort of dark circle is we're referring to macula there. And all the other parts of the retina also works hard, but they innervates your peripheral visions. So mainly you'll be more using your central vision more than your peripheral vision. Hence the macula is very important. So going back here about the cataracts, how does diabetes cause all these issues? Diabetic retinopathy, cataracts, and sometimes you may hear your risk for developing glaucoma with diabetic eye disease is high as well. Well, as I said earlier, the diabetes do change your vessels. For the eye specifically, is a microvascular changes. Micro means small, vascular means we're referring to vessels. And you can imagine it can affect all those small vessels at the back of the eye where providing nutrition to the film part of your eye, which is the retina. So the term diabetic retinopathy, the retina is a retina. Pathy is we're talking about disorder of the retina. And you also may hear sometimes clinicians referring to or worry about diabetic macular edema. So this is we're talking about swelling. Edema means swelling of the macula caused by diabetic eye disease. And going to the cataract, a cataract refers to the opaqueness of your lens. If you live long enough, we're all going to have a cataract at some stage or certain degree. And we all have probably different visual disturbance from the cataract. But what can happen with the diabetes is that this vitreous body and the front part of the eye called anterior chamber, and they've usually filled up with the fluids. So anterior chamber got what we call aqueous humor. Vitreous body is filled with vitreous humor. Now, when these fluids contains high sugar molecules, then your lens will swell. Now, the swelling of the lens may temporarily can cause actually a better vision when you try to read, almost like it works like a magnifying glasses. Having said that, it doesn't last long. It will slowly cause blurriness and the formation of the opaqueness forms, and then we're referring to cataract. And if you're diabetic eye disease, so those who unfortunately have diabetic retinopathy and continues to have progressions, and that can cause what we call neovascular glaucoma, where the new vessels are growing and covering up the sewage part of your eye where your water meant to drain out. Unfortunately, because of new vessels, your eye water doesn't drain much. And hence you have developed a secondary glaucoma. This is usually referred to the late stage of your diabetic retinopathy. So what your eye clinicians is looking for, I suppose a lot of people will see optometrist. Some of you go and see ophthalmologist and get your eyes checked for various different reasons. It is very important that you do get your eyes checked regularly. We're very fortunate in Australia. The optometrists usually bulk bill the general ophthalmological checks, and they may use slit lamp like what you're seeing on the left-hand side, and they can dilate your eye. When I say dilate, we're talking about the pupils. So we're trying to look inside your eye, and your eyeball's about the size of cherry tomato. And as I said, we want to have a look at the back wall where your retina is. So we want a bright light trying to focus with this lens that this clinician is holding up with this device called slit lamp, basically a microscope to look inside your eye to see your tissues. And sometimes in ophthalmology areas, or optometrists can utilize fancy cameras or very expensive tools to take photos or scans of your eye. You may recall putting your head like a disc jammer on the right side, trying to get photos done or getting a scans done. And there are different types of scans, but those scans are great tools for clinicians to monitor your progress, and we can compare if there's any issues or compared to your previous visit, and we can communicate with the doctors. Now, the photos do speak more than 1,000 words, and I have to say that is very true in that sense. The next slide shows this is what the clinicians are looking for really with the slit lamp, or are using those cameras. So on the left-hand side, we've got a nice, healthy retina. Some of you may feel like this is a bit confronting because it's nice and red with the blood vessels. This is very healthy retina, very healthy macula here. On the right-hand side, we got a somewhat moderate to severe progressed non-proliferative diabetic retinopathy. So, typical example of lots of different features. You can sort of tell on the right side there's a few flame hemorrhages and lots of bloods, some unusual white spots we usually refer to cotton wool spots. Funny, this yellow deposits known as hard exudates in your back of your eye, the retina. Now, when we say macula, so that's this little small spot here where I'm circling with my mouse point here. Or in the normal retina is around here. And as I said, this macula is very important because it's providing you the vivid vision. So there are about 4 stages of diabetic retinopathy we clinicians do stage patients. First of all, we say mild non-proliferative diabetic retinopathy. Now, the proliferative, the term we are referring to new vessels. So when we say mild, which means you've got less features in your eye, but there's no proliferation of the new vessels yet. So it's a good thing. And then there's a second stage is called moderate non-proliferative diabetic retinopathy, which we sort of tend to see retinal hemorrhages, hard exudates, and cotton wool spots prominent in the back of the eyes. And if there's a lot more features of these, then we would put stage as a stage severe non-proliferative diabetic retinopathies. And to that stage, we don't see the new vessels yet. And then the last stage is, unfortunately, it's called proliferative diabetic retinopathy. This is a bit more severe, serious stage where the ophthalmologist would be more aggressively discuss the treatment options with the patients. And the word proliferation of a new vessel, the new vascularizations, in a simple way of explaining it is, when we are young, we all cause troubles. When we're in adolescence, when we're in puberty, we usually cause troubles, right? Same thing with these new vessels. So these immature new vessels that grows at the back of the eyes, they tend to leak blood, they tend to burst out and leak fluids into the retina. So it's like your very expensive suede carpet have someone just spill water on it, a large amount of water that is. And then the clinicians trying to treat you or trying to optimize your diabetic health, and then the fluid may retreat a bit, then your suede carpet is now all well and truly dried, but the shape and the feeling would know the same. Same as your retina. I mean, we can try to do our best to improve your diabetic retinopathy, and the fluids may retreat Your vision may improve slightly, but that the structure or the scar tissue caused by these changes will never be the same. So you'll never get a crisp vision back if you have a moderate progress of your disease. So hence, I'm trying to stress out that prevention is very important, and trying to recognize that your diabetic retinopathy is very, very important. Going through, so when we see you, whether you see a doctor or optometrist, we'll be asking you some of the questions. I'll be asking, do you have any symptoms related to your visions? I'm talking about things like black spots. You may see some distorted images. You may see just general blurriness. I might see some flashing lights. Or those just sounds like a bit non-specific, but those are very important for us to be aware. And then we also, of course, examine your eye with the tools, slit lamp, and we do a dilating eye exam, take photos, and see what sort of clinical signs you present with, and we can stage your diabetic retinopathy if you do have any. We can also compare with any progress, so it will tell us how quickly progressing. And we'll be asking you about how well your diabetes are controlled. And this is not something that the ophthalmologist do. We'll be referring you to see your family doctor or your endocrinologist. They are the expert, endocrinologist expert in looking after your diabetic disease. And we can work together as a multidisciplinary team to ensure we can report and telling the endocrinologist that what's happening in your eye. As I did mention that diabetic eye disease is microvascular changes, which means small vessel changes. And as the previous slides, the diabetes affects other organs as well, like your kidney, heart, or any other organs that provides blood for nutrition, which is pretty much everywhere. So if you do have changes in the eye, then likely there is other organs may be impacted or having changes with diabetes. So the endocrinologist will be able to do more thorough investigations. So we can work together. The key person is the patient or yourself. It's really important that you do visit regularly with your opticians or ophthalmologist, and ensuring that we can see if there's any progress, or there's no progress, then yay, we're very happy. Okay, there's another slide that I'll show you. Maybe you may have seen this image on the right with your ophthalmologist, and you may not quite sure what they're talking about. This is what we call ocular coherence tomography. Those who work in the trade and things construction work are probably quite familiar with stud finder. The concept is similar. So basically, we like to have a look at your wall, the retina, back wall of the eye. And when we have a look at it, we can see what's happening on the surface on this side, where I'm just circling my cursor. But what we're also interested is about the photosensory cells known as rods and cones. We can sort of refer what's happening on the surface of the back of the eye, on the retina, and what's happening in your cones and rods. But this scan sort of tells us what it looks like. So in a sense, that wall, it correlates like this. So if this is the back of the eye, right? No, oops, sorry. Then rods and cones, you can sort of see nicely along the epithelial cells. And so this is basically what we're looking for, and that's a macular shot. And this scan is very useful for ophthalmologists to be able to see if you have any diabetic macular edema, which is a bit more scary looking here. These definitely doesn't look like what you saw just then. Lots of pockets of fluids, these black spots. This is known as cystoid macular edema, which means the cystic-like fluids are in occupying macula. So if you compare to the previous slide, what was a nice and flat with I did there, which is nicely swollen, almost like a blister of some sort. So there's fluids going in. And if you imagine a film with lots of water, you would not have clear vision. And hence, the diabetic macular edema does impact your central vision and people would notice you got a very blurred vision. No matter what glasses you change, you will not get better because it's not a lens issue. It's about the film having the issues. So I've got diabetes, Tay. Does that mean will I get blind? Do I have to really worry about it? Well, unfortunately though, the chances are higher if you don't do anything about it now. The statistics shows that very likely most of people who have diabetes will develop some degree of diabetic retinopathy. And what the whole purpose of this talk is really trying to alert how dangerous this disease is and try to prevent before you're having a significant vision loss. Because by the time that you've got a significant vision loss, it's a little bit too late. And even though we can optimize your health and try to get your vision back, we may not be able to restore your crisp vision. Now, so the studies that is done in 2016 onwards basically shows that the longer you have diabetes, the higher likely that you will have diabetic macular edema or diabetic retinopathy. Now, the study was done in 2017 was looking at what is the percentage of people having diabetic retinopathy. It was about 47% in type 1 diabetes patients have some degree of retinopathies, whereas type 2 diabetes patients have about 26% or other. Well, adding all together, that's pretty high. And in general rule, probably about 1 in 3 diabetic patients will have some degree of diabetic retinopathies. But fortunately though, if you only have a mild diabetic retinopathy, then it may not have impacted your vision yet. In that sense, if you can optimize your sugar levels and control your diabetes well, then you may be able to maintain that stage, and hence you can prevent you having significant vision loss. The other scary factor is about your ethnic background as well. Now, I understand that the Australian and Indigenous populations are very vulnerable with diabetic disease as well, and they can't escape diabetic retinopathy as well. The study was done with Australian Indigenous populations. Well, about 75% of those patients in proliferative, so that's a stage 4, this proliferative diabetic retinopathy, had developed somewhat the macular edema, and there was about 75% of patients in that study. So that's quite a large cohort of patients developed diabetic macular edema and lost their vision. So what can you do to reduce your risk? Well, let's think about what can you do or what can't you do. So as I said, there are predisposing factors like race, ethnicities, your age is a factor. If you have a family history of diabetes, you're likely to develop one too. Strong genetic factors would plays a role in here. Unfortunately, you can't change that. We can't get any younger than what we are now. So let's think about what we can change. So modifiable risk factors. So those involves physical inactivity, so you can be a bit more active, exercise. If you have a high BMI, body mass index, or if you have just generally a bit overweight, then you can lose your weight. And if you have a high blood pressure, the high blood pressure is also contributes to progressive the changes happening in your organ due to diabetes. So it is really important to optimize your blood pressure. Ideally, you want to have somewhat below 140 over 90. So it's really important to take your blood pressure tablet on time, regularly, and seeing your doctor and checking your blood pressure. And also there's, as I said, it is a vascular disease in the sense that you should optimize your cholesterol level. That's again, regularly seeing your family doctor, checking your bloods to see whether you've got a healthy cholesterol level, something you can optimize. And all together, really coming down to 2 factors. Be active and exercise if you can, and that will hopefully contribute to body weight loss. And seeing your clinicians regularly to check your health and optimize in any means with your health. So that's just in they're trying to make it very simple here. As I said, A, B, C, D, E's. This is slightly modified version of what UK website had. I thought it was very useful for our publics. So the managing your diabetes, as I said, A, for essential risk factors, what we just discussed so far. B, do your blood test regularly. Now, the finger prick test for sugar is very important. And you can also have a formal blood test to see what your HbA1c level is. And you may have heard that HbA1c test before. This is somewhat like average your blood glucose level over the last past 3 months. So it gives a very good understanding to the clinicians, because you may have a really bad fluctuation of high blood sugar level and then it comes down low. And sometimes when you check your sugar level, it's fine, it's about 6, 7, I'm happy with that. But then you may have overindulged yourself and finish a whole pack of chocolate perhaps, and then your blood sugar level might shoot up really high. And if they stay for a long time, you haven't checked your finger prick test, then HbA1c is a really great tool to sort of have understanding of what your average level was in the last 3 months. C, to check with your doctor, of course. So what you can do, that may be you're modifying your medications. If your diabetic control is not great, then you can optimize your trying different drugs, or even having a discussion to see whether you're eligible or appropriate for insulin treatments as well. And diet plan is very important. So again, I kind of mentioned, if you overindulge yourself, then obviously your blood sugar level will go up. If I finish, even though I'm a healthy person, finish a packet of chocolate by myself, being greedy, then my sugar level will be very high right afterwards. So it's really important you watch out your diet. And it's not just about the sugary chocolates, lollies and things like that. It's really important you also think about what you eat every day. I'm Korean as background, so I eat rice every day pretty much. And the rice, the carbohydrates, when they're broken down, they become glucose and that's your sugar. So just have a think about when you eat, trying to go into more different diets, variety of green veggies, multi-different types of legumes would be great. They're really important to you. And ease for exercise, so physical activities, and by all means, I know we're in COVID, we're staying at home, we're trying to be active as much as possible. Pretty simple. The more you consume, and if you exercise enough, then the sugar level in your bloodstream will be ideally lowered down due to the usage of your sugar in your bloodstream. It's really important. Please, if any of you smoking, please stop smoking. The smoking will make your diabetic eye disease much worse, and it also make other diseases much worse, and it would impact down the tract as well. So please, if you're smoking, please do consider either reduce your amount or stop smoking. Let's talk about the treatments of diabetic retinopathy. This is a bit more scary side of the treatments. As I said before, I keep repeating myself, the prevention is the key. And optimizing your diabetes is the key, really, to make your diabetic eye disease better. That's the fundamental. So when you come to see ophthalmologist and optician, what do we really do? If you have a mild disease, then we'll be just monitoring you, and we're making sure so we can alert the endocrinologist at the right time. Now, those who's unfortunate who had progressed into more severe stage, mainly for type 1 diabetes, then we can talk about offering you like a retinal laser treatments, or you may heard about scary eye injection, literally a syringe needle to the eye of anti-VEGF, or steroid injection to the eye, or the doctor may offer you surgery. Now, well, can I just get just treatments when my eye diseases are bad? Well, no, the prevention is a key, because by the time that you already develop severe stages, I mean, yes, the ophthalmologist can do our best to stabilize it or slow down your progress, but these are not definitive treatment. The definitive treatment is to optimize your sugar control. Whether it doesn't matter type 1 or type 2. There was a study was shown that those patients who's got very compliant to diabetic medications and stick with their routine, tight schedules, watch out with diet, with their physical activities, their progressive diabetopathy was much slower than despite those type 2 diabetes poorly controlled, high fluctuation in their sugars. So it's really important, again, make sure you optimize your current diabetic status. All right. This slide, I just want to say, trying to say what happens after the laser treatments. Some of you may already have the treatment done. Now, if I refer your retina as like the capital of the city, sorry, as like a nation, the macula is where the capital city is, where the most populations are accumulated there. So lots of photosensory tissues, cells are down there, and it provides you high definition vision. So with a severe progress, what the clinician is doing with the red laser, as you can see those little spots in the right-hand side, that's the laser marks where patients' peripheral side of retina is now destroyed. But they have actually lost vision in their peripheral side. Now, why are we destroying? Oh no, why is doctors destroying retinal tissue? The fact that they're seeing blur vision. Well, it's because we're trying to save the most important, the visual functioning part, which is the macula. So, and what we're trying to do here is, as I said, when your eye is working, when you're looking at image, it's working very hard. And what we're trying to do is destroy all the peripheral side, so then the deriving factor for nutrition to the retina is minimized. Makes sense. Now, we also know that if the deriving factor for nutrition is high and the diabetes is causing all these changes in the vessels and the eye is unable to get all the nutrition, what it does, it will start to swell. And what happens if you have blocked road? Well, we can create another road to bypass. Now, that road in eyes, it's called immature new vessels. So we're referring to neovascularizations. That's the proliferative stage. When we see those stages, then we become more aggressive about our treatment options. So yes, the laser treatment is trying to salvage your vision. So it's not a great thing. So we like to prevent the diabetic retinopathy to progress if we can before we hit this stage. So a bit of a quick recap. Repeating multiple times, prevention is the key. And please see your clinicians regularly. What is regularly? What the clinicians say. So depending on your level or your stage of your diabetopathies, we may ask you to come through different intervals. General rule is if you don't have any signs, you should see your opticians every 2 yearly, just to make sure that you don't you pick up other eye disease as well. There's other progressive disease, things like glaucoma, cataracts, and there's other disease out there that the opticians can actually screen very well. If you have somewhat mild, moderate to severe non-proliferative retinopathies, then the clinicians will advise you to come more frequently. And those severe ones and proliferative stages with the ongoing treatments, I did mention the ongoing eye injections. That can be as frequent as 4 weekly injection to your eye. Can you imagine having a needle to your eye every 4 weeks? And of course, if the treatment goes really well and stabilizes well, then we can extend that duration with different types of medication options. And it can be extended up to like 3 months or a bit longer. But at initial stage, you may get 4 weekly needle to your eye. That's very scary for me, myself. And if you can optimize any of your risk factors, like, for example, smoking, blood pressures, cholesterol, or being active, just going for a simple walk down, go outside, go for a walk for half an hour. If you haven't done that for a long time, that's really good. If you're sitting at home, just reading books is great, or watching TV is great, but please just stand up, stretch your legs, and go for a walk. and increase your physical activities. Just reducing your risk factor is really important. So as I said, prevention is the key. So that comes to the end of my talk. Now, I'll hand it back to Neve and take any questions if you have any.
Excellent. Thank you so much, Tay. Just get back on the screen myself. Perfect. Great. So thank you so much for that, Tay. That was really informative. I think we all learned a lot from that and a lot about diabetes. So if you do have any questions about anything that Tay spoke about, you can, of course, ask a question, and I'll just refresh your memory as to how to do that. So you just click on the questions icon, type your question into the white box, and then press send. Easy as that. So now, before we move on to the questions, I just want to briefly speak a little bit about what we do here at the MDFA. So our goal is to reduce the incidence and impact of macular diseases, and we do this through a number of pillars. The first being in prevention and early detection. So we provide accurate, current, and ongoing information. Just last year, we reached almost 7,000 people doing talks such as this one. We aim to raise awareness about macular diseases and encourage people to get their eyes tested regularly for early detection, just like Tay mentioned. The second is in support and services. So we provide support for all patients and facilitate access across other support services as well. We aim to support people living with macular diseases to continue to live well. We are proud to be the voice of the macular community. It is our privilege to advocate for the very best interest of the macular community and to ensure they continue to live well and have access to the supports and services required to live well. And lastly, research and data. 100% of funds donated to research go into our research grants program. Oh, seems like you can't see my screen. I'm sorry about that. Hopefully you're able to see it now. I'll just turn Tay back on. Tay, are you able to see my screen now?
Yes, I can see your screen. Thank you, Neve.
Sorry about that, everyone. All right, well, hopefully you'll be able to see now. So we went through prevention and early detection, supports and services, voice of the macular disease community, and now we're up to research and data. So 100% of funds donated to research go into our research grants program. And since 2011, we've given over $4 million to 21 different research projects. We aim to promote research for better health outcomes, and our CSI surveys inform what we do and provide an evidence base for stakeholders and decision makers as well. So now this is how we can help you. You can contact us on our toll-free national helpline number, which is 1-800-111-709, for any questions you might have. Not only about diabetic eye disease, but if you have a question about how My Aged Care works or how Medicare works, we can help you out there as well. If you have someone who doesn't speak English as a first language, we can also provide translated materials as well. We have a wealth of resources that we're able to send out to you free of charge, and you can view all of our resources on our website, www.mdfoundation.com.au. So I'll bring back Tay now, and we'll go through a couple of your questions because I can see we have quite a few coming through now. Let's see. Excellent, great. So the first question here, are hard exudates similar to hard drusen?
See, somewhat different, no, but so hard exudates is a more of as a lipid deposit in the retina, whereas a drusen is you probably hear more commonly in macular degenerations, where it's like a waste product is deposited in. So in terms of a clinician's point of view, we still see yellow deposits on this view, so that photo that I've shown you, but they're two different things and with the two different causes.
Okay, excellent. So let's see. I have high blood pressure and high cholesterol too. How does that affect diabetes?
Sure. No, I'm not a diabetic expert, so I can't really answer how blood pressure can impact the sugar control. There's a very, very complex cascade of what happens when you consume food. Having said that, though, the reason I keep mentioning blood pressure and cholesterol It's because the impacts on the organs and the damage that causes. So it's like multiplies the impacts on your organ. Think about like water hose. So the water is your blood, and now there's high pressure in the water hose, and the water hose might get a bit weaker with time. It might burst out. So that's like an aneurysm. And in fact, there's this hemorrhage, small hemorrhages that you saw in my photo before, the front photos, and those are little microaneurysms that you could see. So blood doesn't burst out because of high pressures. Now, cholesterol, now adding that high pressurized tube, there's now a small stuck in that tube, then it makes the situation a lot worse because the cholesterol will stick on the blood vessel wall, and yes, it can cause a rupture, clots, and cause all sorts of different problems. As I mentioned before, diabetes contribute to those several vascular disease like a stroke. If it happens in the heart, then you can have a heart attack. So look, I mean, if you can optimize diabetes, that's the best thing you can do.
Yeah, exactly. So if I have, I think you kind of answered this already, but if I have diabetes, how often should I be visiting the optometrist or the ophthalmologist?
Great, good questions. So it again depends on your diabetic retinopathies. The opticians and ophthalmologists are able to screen and monitor your progressive diabetic retinopathy. Now, having said that, you may not actually have diabetic retinopathy. Great, yay! But the idea is if you don't have it, then see regularly, at least 2 yearly, so that if you do develop, then you catch early. Now, if you do develop diabetic retinopathy down the track, as I said, we may ask you to come back much more frequently, in a sense that maybe every 6 monthly than yearly kind of basis, or even 3 monthly. It depends on your status of your diabetic retinopathy. Now, the opticians and ophthalmologists won't be able to intervene how the GP is recommending you about what tablets or insulin regime, and that will be more role of family doctor, and on the complex matter will be endocrinologists. So we may are known to diabetic services in public hospital with diabetic educators, often nurses who does that role. And they're the expert in that sense. So the opticians or ophthalmologists will probably not be able to contribute too much about the actual diabetic problem itself, but we can actually talk to your endocrinologist and say, hey, this is what's happening with our patient's eye. There's a risk factors there. Can we try to tighten the sugar control? So we can communicate in that sense.
Great. It's kind of like multidisciplinary, like you kind of everyone works together for the benefit of you almost.
Definitely.
Another question is, does having gestational diabetes also increase your risk as much as type 1 or type 2?
Interesting questions. Yes, it does. Gestation diabetes does still increase the occurrence of diabetes. But then the issue that I have is more that the gestation diabetes becomes type 2 diabetic afterwards. Like after you've given birth, then it kind of stays with you. Hopefully, after you've given birth, the diabetes goes away. Then yay, we're happy. But then if you haven't developed a diabetes, then again, you'll be back into the same quarter of type 2 diabetes. So at the time when you're noticed with gestation diabetes, I believe when I was in North Shore, we actually did see some of the patients when you're pregnant and have developed a gestation diabetes, and if you've got some blurred vision associated with it, if you're symptomatic, then yes, those symptoms are commonly as blurred vision, black spots appearing, or flashing lights. Whether you're pregnant or not, if you have these issues you're concerned about, please do see a clinician. But generally speaking, if you're pregnant and have these visual symptoms, then please see the optician or ophthalmologist.
Okay, excellent. If I already have changes at the back of my eye, can these be reversed?
Somewhat, yes. That's the idea of all those scary treatments options I've mentioned so far. The laser treatments and the eye injections, like the eye. That's very scary. But yes, that's correct. So we can try to optimize your retina, but as I said, I've used a suede carpet as an analogy before. I mean, we often talk about, doctor might say, oh, we're drying out your macula, or you're drying out your retina. So we're talking about the fluids that is captured in the retinal tissues. And no matter how we dry out and bring the fluid back in, and you may have less swelling, that probably will make your vision slightly better, and the clinician might be happy. But that change, so your suede carpet, which is your retina, when it dries out, the structure and the shape would never be the same. So yeah, so unfortunately, the scar tissue that causes in the retina will cause you the distorted vision, blurred vision as well, and those won't go away.
Yeah,
you won't get blinded from this. Well, you can, but if you have, say, let's say, moderate and had a bleed at the macula, and we can do operations, injections, treatments, trying to make it be better, but it may not be crystal sharp vision that you had when you're young.
Yeah, it's also about trying to keep the vision that you have at the time and not allowing it to progress to those later stages where it could get worse.
That's exactly right.
Okay, perfect. And then one more question. If I wanted help to maintain a diet plan, is there someone I could talk to?
Of course. Now, I believe the Macular Disease Foundation do offer that service, and I have spoke to many of my patients who refer to Macular Disease Foundation, and there is a dietitian Australia. So your GP can refer you to the dietitians if you like to seek private dietitian. That's an option as well. And generally speaking, well, if you stick with the green veggie, seafood, lots of colorful food, and try to stay away from the white bread and white rice, then I think you're on the right track.
Yeah. I think everything you kind of spoke about in the ABCDEs as well, just
Yeah,
all of that, getting the good exercise and the good food, and of course not smoking, which is a big one. By doing all of that, you're kind of already on the right track, but I think GPs and dietitians can definitely help you out on your journey as well.
definitely.
Perfect, amazing. I think that concludes all our questions for now. Thank you to all of you for asking those questions, and thank you to you, Tay, for answering all of them with such expertise.